Auzubillahi minash shaitanir rajim. Bismillahir rahmanir rahim. I welcome you all for this scientific session of today, second day of ChemCon 2020. So till now, we have got how many participants? Yes, we've got 21 participants online. We begin today's session with the recitation of Holy Quran.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم ألم نشرح لك صدرك ووضعنا عنك وزرك الذي أنقض ظهرك ورفعنا لك ذكرك فإن مع العسر يسرا إن مع العسر يسرا فإذا فرغت فانصب وإلى ربك فارغب.
Jazakallah. With the permission of the chair, our patron, Professor Dr. Abdurrahman Saab, will start the session. So today's the first presentation is from Aga Khan Medical University, and Professor Aisha Habib Khan will be there. Ma'am, have you joined us? Let me introduce Professor Aisha Habib. She is the most humble, talented, and having a very high research acumen. She is a renowned faculty at the Aga Khan University. She is a supervisor, examiner, assessor, and fellowship of chemical pathology at College of Physician and Surgeon, Pakistan. She is a member of International Collaboration Division of Pakistan Society of Chemical Pathology for International Federation of Clinical Chemistry, and also a member of Asia Pacific Federation of Clinical Biochemistry. She is a member of Academic Council of Society of Study of Inborn Error of Metabolism, and is a member of International Osteoporosis Foundation too. She is an executive member of Asia Pacific on the osteoporosis, and she has got more than 11 publications only on this subject alone. And now she has become an active member of Society of Etiology and Prevalence of Renal Calculi Understanding in Pakistan. I welcome you, ma'am. Please start your presentation.
Thank you. Can you all hear me?
Yes, ma'am, we can hear you.
Okay. Assalamu alaikum. Thank you, Sabahat, for your introduction, and respected teachers, colleagues. Assalamu alaikum again. And it's a great learning experience to be here today at this forum, because it's a it's first time experience for all of us. So first of all, I would like to thank Dr. Abdurrahman and Dr. Sabahat for organizing this wonderful event and inviting me for this talk today. Indeed, it's a great pleasure to be here today among our colleagues from all over Pakistan and to see our speciality growing and glowing, mashallah. Today the topic of my presentation, as you can see, is on rare disease, and you can see the title here is Reframe Rare in Pakistan, Way Forward for Chemical Pathology. Regarding the title, I would like to say that everyone has been made for some particular work, and the desire for that work has been put in every heart. And the desire and compassion to reframe rare in Pakistan in order to help the patients with rare diseases was put in my heart. And today is a step forward in this long journey as we bring suggestions to reframe the landscape of the rare genetic diseases at this platform of noble chemical pathologists. I have nothing to disclose, and here is an outline of my talk. As you all know, it's a very vast topic and there's a lot to share. But within the given time, the outline of my talk will be that after a brief introduction on rare diseases, we will discuss the nomenclature and classification and the different diagnostic tools. And this is followed by a discussion on status of rare diseases in Pakistan and way forward for chemical pathology. So what are rare diseases? As far as its definition is concerned, there is no single widely accepted definition of rare disease, and rare disease is regarded as any disease that affects a small percentage of the population. And this also varies from country to country. For example, in European Union, fewer than 1 in 2,000 people within the general population is regarded as to have a rare disease, and in US, fewer than 200,000 people. So currently, there are over 7,000 known rare diseases, and the number continues to increase with the advancement in technology. They are chronic and life-threatening. They can be single gene, multifactorial, chromosomal, or non-genetic in origin. Majority have no effective treatment, but there are few conditions which, if diagnosed and treated early, can prevent developmental delay and mental retardation. However, for effective treatment for most of them is not available. So rare may not be so rare. Individually, the disease may be rare, but if we look at their cumulative prevalence, the prevalence is high. And currently, there are more than 350 million people globally who are affected by rare diseases. Of the known 7,000 diseases, 80% of these are genetic in origin, affecting mostly children, more than 50% of rare diseases, whereas 30% of the patients die before attaining the age of 5. So improved understanding of rare disease is key for accurate and timely diagnosis and for management. However, there is a significant diagnostic delay around the world, with an average of 4.8 years to diagnose a patient, and after seeing approximately 7 to 8 physicians in countries where the programs are in place. And the reason for this diagnosis delay is because not only the patient and families, but also physicians have limited awareness. And secondly, the symptoms are often hidden behind more common illnesses like sepsis, and they may initially appear to be of minor concern. And then rare disease symptoms may not always be evident, and the doctors and the nurses who handle these cases may have never encountered the disease, as they are rare cases. So the impact to the patient is disastrous, as delayed diagnosis may lead to inappropriate management and disease progression with delay in development and mental retardation. Then misdiagnosis can lead to wrong interventions at time and waste of resources that may have been used in other aspects of patient care. So now we move to the rare disease nomenclature, and this nomenclature that I'm sharing with you is from Orphanet, which is a standardized and controlled database of all clinical entities which are registered in this. So each clinical entity has the following elements, which I have listed here. The first one is a code, which is labeled as an ORPHA code. And this is a unique numerical identifier, which is assigned randomly by the database upon creation of the entity. Then we have a preferred term. And this term is the most generally accepted name according to the literature. And then synonyms and acronyms are terms that are equivalent to the preferred term. And then there is a keyword for every clinical entity. And these keywords are clinical terms for a disorder or a group of disorder. These terms are included to ensure that appropriate redirection of users towards relevant entities can be made. And then finally, there is a definition. And this definition is a short text which states the group of disorders on basis of clinical characteristics. For example, whether it's clinical and pathological, radiological, and other features. As far as the classification is concerned, the rare disease classification is a multi-hierarchical and polyparental classification system, and it is structured around the major medical specialities. So when I say multi-hierarchical, that it means that it is based on clinical criteria according to diagnostic and therapeutic relevance into 3 hierarchical levels. One is the group of disorders, and then is the disorder, and third is the subtype of a disorder. For example, and this is best explained by this example, For example, consider this atypical hemolytic uremic syndrome. And the main category in which this is placed is rare renal disease. And the clinical group is thrombotic microangiopathy and hemolytic uremic syndrome. Then there are two etiological subtypes. One is the atypical hemolytic uremic syndrome with anti-factor H antibodies, and the other one with complement gene abnormalities. So, and when we say polyparental, then this is based on, there is, so this is, I think there is a miss slide here, and like here it is, so this was a repeat slide. So polyparental is when the clinical entity included in many because the clinical entities can be included in many classification groups depending on their clinical presentation. So each entity in the database orphanate has been assigned one preferential group, which is called preferential parent. And in order to enable the sorting out of all clinical entities by medical specialty and to avoid multiple counting of entities in statistical analysis, so this is a safeguard principle. And this can be best understood by this example. And again, reconsidering example of atypical hemolytic uremic syndrome. So the preferential parent, as we discussed earlier, is rare renal disease. However, this atypical hemolytic uremic syndrome is also placed in rare hematological disease anemia group. So that explains that why this is important, because the manifestations of rare disease may vary and may present with diverse manifestations with different specialities. So another example from chemical pathology perspective is that of inborn errors of metabolism. And this is how the orphanate database appears for IAM. As you can see, the rare diseases are classified into further groups if you click them. And if you see further, the inborn errors of amino acids and other organic acids metabolism, then it will open up for specific disorders. So rare inborn errors of metabolism, disorders of amino acids and other organic acid metabolism, and it will give list. Here I have clicked on phenylalanine or tyrosine metabolism, then phenylalanine metabolism, and phenylketonuria is the disease. And then there are subtypes of phenylketonuria. So I would suggest everyone to visit the database for improved understanding. So now we move to the tools, the main tools for diagnosis. And as you all know, that the main diagnostic tools currently are multi-level omics informations with clinical phenotypes and cohesive bioinformatics platforms. And this is for linking to genomic and proteomic, transcriptomic, and metabolomic studies. But then there is a lot that can be diagnosed in our routine labs as well by conventional assays. And then obviously there is a newborn screening which comes under laboratories. But however, I would like to emphasize that newborn screening is a system and it's not just a test. And this system has 5 main components, and screening is only the first step. And you can appreciate here that while screening and diagnosis is a one-time event in this newborn screening system, it is essential that short-term and long-term component management and evaluation, which spans across the entire life cycle of a patient, should be monitored. And again, while there are many components of a follow-up screening program, but a very important role is that of specialty consultants and specialty service provider and screening and diagnostic laboratories. So laboratories have an important role to play. This is the model of a short-term follow-up that begins when the laboratory obtains an initial result that is a screen positive, and ends when there's a confirmatory diagnosis and documentation that appropriate treatment has been initiated. As far as the status of rare disease is concerned in Pakistan, a sort of baseline literature has evolved in the last decades from different centers of the country, highlighting the presence of a number of rare diseases. But the reports on outcomes are very worrisome and painful. And this report, which describes a 5-year experience from Pakistan, shows that majority of parents declined any kind of investigations due to the high cost involved in testing and transportation of samples to overseas labs, and because there is non-availability of local facilities. There were patients who were given diagnosis, but treatment was not prescribed to them by doctors. And then there were majority of patients who were who were started with treatment, but they were unable to continue treatment due to local non-availability of food supplements and medicines. And then there was parents' inability to import on a regular basis because of associated high cost. And then there is very high mortality for these patients. So if you look at the efforts from different institutions across Pakistan, a lot of contribution has been made. Like, for example, this is from AFIP, Dr. Aisha Hafiz, Dr. Amir and their team has worked a lot. Then there's a group in Lahore where this group led by Dr. Farkhunda Kapoor developed a newborn screening program for congenital hypothyroidism. We have a charity organization, ZB Foundation, who started newborn screening across Pakistan. And then there is a very active group at Children's Hospital Lahore who is actively engaged. And recently, a report in Dawn describes 2,000 cases being diagnosed with collaboration of Germany from Children's Hospital by Dr. Machina. I also came across this report or this mutation database by a group from Hosptial University in KBA. But if you look at the statistics from Pakistan, Pakistan continues to have highest neonatal mortality with survival rate of newborns, which is ostensibly worse than many other countries with compromised economies as well as weaker health infrastructure. And we continue to have very high infant and under 5 mortality as well. And if we look at the timing of neonatal death over the causes of the neonatal death overall and disease-wise, we see birth asphyxia, stillbirth, pneumonia, diarrhea, and low birth weight as the major causes of neonatal infant mortality. And this is partly as a result of the focus on these problems. Inherited metabolic diseases have been relatively ignored by both the government as well as the private sector, and they are not considered in the workup of a sick newborn. While poor maternal health and nutrition, poor provision of available obstetric critical care are important, they still do not explain why Pakistan's newborn mortality rate would be higher than any of the other countries listed in the top 10 of UNICEF's list. As this report, the author writes, there are probably additional factors in Pakistan that need scientific exploration, such as cousin marriages. And we all know that we have a very high rate of cousin marriages, which increases the risk of genetic disorders in subsequent generations. The burden of genetic disorders and its impact in the overall newborn and maternal mortality is currently unknown in Pakistan. So what has been experienced so far in Pakistan is just the tip of the iceberg, and it is expected that the underlying burden of rare diseases is much larger than expected. And it is high time for all of us to think that how we should be moving forward on rare diseases, as the resources for development are never enough. And it is very critical to make the best possible use of existing understanding and ensure that efforts are not duplicated. And the main challenge is that of rarity. Not only the patients are rare, experts are rare too. And most tests are laboratory developed and of high complexity. And what we have learned so far that the diagnostics has to be with infrastructure to provide adequate follow-up care and clinical services. And patients should not be left with a diagnosis, but no resources and means to treat it. Access to treatment and long-term follow-up is a must, and outcome at all time should be assessed. So the way forward is to come together to create partnerships and synergies and non-competitive collaborations. And the drive should be towards a common goal. Using collective intelligence can have a multiplier effect in bringing an impact in national health policy, provincial policy, and plans for implementation. So it is important that processes, content, and data must match to drive operational improvements. And for this, to achieve this, the power of togetherness is hugely impactful. So it is high time that we should all think as a nation that how we should be moving forward on rare diseases, as the resources for development are never enough and we need to think out of box. So we propose developing a consortium on rare diseases, and significant collaboration and cooperation between scientists, politicians, and policy makers, healthcare practitioners, and patients is essential to continue to drive public health policies and improve care. A major objective should be to design methods so that approaches which are developed at specialized and resourced tertiary care centers, which have access to patient cohorts in diagnostics and genetic information, can be adopted in less resource intensive settings, which in fact covers most of the population. So our vision for breaking down silos and bringing synergy together into an intuitive experience that puts people at the center. And I conclude here with this beautiful photograph to show that great things are never done by one person. They are done by a team of people working together towards a common vision. No one organization owns nor can claim to own all the answers, but many can contribute when they consider it as a true strategic focus at the heart of healthcare. And I leave you with these beautiful photographs to show that in experience every voice matters, and each of these individual voices contribute to an ocean of ripples that can positively impact countless lives when everyone is aligned around a shared vision and focused values, complementing and collaborating each other. So, and this is my last slide, and I know that the Cam Gems, if they come together, like organizing this event, they can do a lot. Thank you, and it is better to light a candle than to curse the darkness.
Thank you very much, ma'am. Thank you very much, Professor Aisha Habib, for introducing us to this rare reframe, which is not so rare as the data shows. There are more than 6,000 rare diseases till date. And the day for the awareness of this type of disease is usually celebrated in the February of every year. But this, as shows the chemical pathology, and the chemical pathologists have actually the basic role, the basic tool they provide in the diagnosis, screening of these rare diseases. And the chemical pathology, the role of the chemical pathologist and in the rare disease awareness was started from the AFIP and in the AHAN, and Shifa has also started screening for the rare diseases as well. Thank you very much, ma'am. And now we have got 48 participants now. I welcome all our respectable dignitaries and the ChemGems for joining us online. Moving further, I will request Professor Naki Zafar from Sindh Institute of Urology and Transplant. Professor Naki Zafar is a professor of pathology and head of laboratories at the Sindh Institute of Urology and Transplantation. He graduated from the University of London in 1975 and obtained his doctorate in 1979. He has got extensive research experience in the area of stone composition, ultrastructure, and metabolic risk factors associated with the urolithiasis. He has got more than 50 publications on this subject alone in the national and the international journals. He is a member of different societies and pathology association. He serves on the editorial board of number of international and national journals. We welcome you, sir, on this forum of the ChemCon 2020 from Sheikh Zayed Medical College, Rahim. Please, sir.
Assalamu alaikum. I first of all would like to thank everybody for the ChemCon for inviting me for this lecture and this excellent effort of doing Zoom lectures. I would like to thank Professor Abdul Rahman, Dr. Amir Ejaz, who I can see there, Dr. Sabahat for all the efforts, and of course, Dr. Tariq Ahmed, the principal of the Institute. The topic of my talk is urolithiasis in infants, risk factors and chemical composition in stones. This is the work we've been doing in SIT for the last 30 years. I have no conflict of interest to declare in this study. Urolithiasis in children remains endemic in low-income countries, especially Pakistan, with estimated rate of up to 15%. And in these settings, infants constitute 17 to 40% of all stone-forming children. So we did a retrospective study to report metabolic risk factors, demographics, history, and stone composition in 487 infants aged from less than 1 month to 24 months. So this retrospective study was done between 2012 and 2017, and data on demographics, medical history, nutritional status, metabolic studies, and stone composition was retrieved primarily from the database of the Chemical Pathology Department, which has stone database of more than 40,000 stones over the last 4 decades. And data was analyzed in 3 groups, infants less than 6 months, 7 to 12 months, and 13 to 24 months. Blood tests included urea, creatinine, electrolytes, calcium, phosphate, uric acid, and magnesium. And a 24-hour collection was done in every infant, was taken by catheterization. Tests included volume, pH, specific gravity, creatinine, uric acid, phosphate. These are all the metabolic risk factors: sodium, potassium, citrate, oxalate, ammonium. Cysteine was done by a screening test, and protein. The nutritional status of infants was determined by a weight for length Z-score using WHO software for Z-score calculation, and stones were analyzed by infrared spectroscopy. So these are the demographics of 487 infants. The mean age was 17, and 66% of the infants were of the age 13 to 24 months, and about 10% were less than 6 months of age at the time of presentation. 14% gave history of stone formation in the family, and the location of stone was mainly kidney 45% and bladder 28%. Nutritional status: majority of the infants were malnourished, about 55%, and almost 10% had severe malnutrition at presentation. These were the parental complaints at initial assessment. As you can see, they're all very vague: abdominal pain, irritability, fever, constipation, diarrhea, nausea, vomiting, dysuria, perhaps more specific, hematuria, oliguria, dribbling, and urinary tract infection. So when they present, they present with very vague symptoms, especially the very small infants. You usually find irritability, fever, and these are the main criteria of presentation. Or you find out because they have passed a stone and the parents come with a stone in their hand that the child has passed a stone in the diaper. So if you look at metabolic risk factors, hypercalcemia was seen in 8.5%, hypocalciuria 3.9%, but the significant was that infants less than 6 months of age had 21% of them had hypercalciuria. This is a busy slide showing metabolic risk factors, but if you can focus, if you can focus here, 70% had low urinary volume. That means they were dehydrated. Hypercalciuria 14%, hyperoxaluria 41%. But if you look here, although 45% had hyperuricosuria In this age group, almost 60% had hyperuria. This is the age group where you get growth spurts from the age of 7 to 12 months. So hyperuricemia was significantly higher in this group. Hypomagnesuria was higher in the older infants, and hypocytituria was also higher in older age groups as compared to the very small infants. Can I go back? And if you look here, hyponatrituria and hypocaluria was significantly higher in the infants less than 6 years of age, and we'll come to the reason for that in later slides. If you look at these factors, clinical factors, malnutrition was highest in infants less than 6 months, diarrhea also in infants less than 6 months, and 17% of the infants in age group 13 to 24 had significantly higher constipation rates at the time of presentation. This is the stone composition in these infants. Of the 487 infants, we could get stones from 342. And out of these 342, 162 stones were pure. That means they were composed of a single constituent. And ammonium acid urate was the commonest stone type in infants in about 65%. But the highest of them, these stones were found in the age group 13 to 24 months. And calcium oxalate was the next stone type. If you can see, interestingly now, uric acid stones were highest in the age group 17 to 12 months. That's the group of infants where we had the maximum hyperuricosuric. And cystine stones were found in younger children, obviously presenting at a younger age as compared to older ages. Majority of the stones, of course, were mixture of two compounds, ammonium acid urate in 76% overall. I can't seem to work this icon, so this my assistant has to help me with that. Ammonium acid urate stones and calcium oxalate stones were the commonest stone type mixtures. But if you can see here, infants who were less than 6 months of age, stones, majority of the stones in these infants were composed of calcium oxalate. So we have a situation here where the two most common stones, stone constituents are ammonium acid urate and calcium oxalate. So what's the pathophysiology of this stone formation in infants? So on one hand, we have malnutrition in the smaller infants. Okay, here. Now, breast milk is very low in citrate. And so these smaller children have breast milk, which is low in citrate. They have formula milk, which has better concentrations of citrate in them. Wheat, germ, and legumins are the main diet. So what you end up with high urates because of this diet, ammonia, oxalate in your urine, low calcium, low citrate, and low magnesium. That's from the diet. If you look at the climate and hot climate, dehydration, diarrhea, you have loss of electrolytes. So again, you have low volume, higher ammonia because of loss of electrolytes, low sodium and potassium in urine, low citrate and low magnesium. So that's the milieu. If you look at the urine, the pH is between 6 and 7. So now this pH, at this pH, although we have abundance of uric acid does not precipitate at this. So you have a lot of uric acid circulating around, so it has to bind with something. So when you have high oxalate and low calcium in urine, uric acid is in circulation. Now, uric acid is shown to be a precipitator. It causes salting out of calcium oxalate. So even if the calcium is low, you would get precipitation of calcium oxalate in presence of low volume, low potassium, low citrate. These are and low magnesium. These are the inhibitory factors for stone formation. On the other hand, because you have uric acid, and it's not precipitating because of the pH, you have high ammonia, low sodium and low potassium, so uric acid preferentially binds to ammonium ions. Now that's the most insoluble salt of urate as compared to sodium and potassium, low volume and low citrate, and again low magnesium, which are the inhibitors of stone formation. You end up having precipitation of reason why you have supersaturation. You get two types of crystals coming into the urine, calcium oxalate on one hand and ammonium acid urate on the other. So now the infants who are less than 6 months of age predominantly have calcium oxalate precipitating with ammonium acid urate, and older infants have predominantly ammonium acid urate precipitating with calcium oxalate. To summarize, in infants, male predominance, biochemistry, hypercalcemia in 8.5%, hyperuricemia in 3.3%. But if you look at the urine, most of these infants had hypovolemia, that is concentrated urine, hypocalciuria, hyperoxaluria, low citrate, low magnesium, low and high ammonium, leading to a mixture of calcium oxalate and ammonium acid urate stones. If you look at the stone analyses, 76.6% had ammonium acid urate followed by calcium oxalate. Infants less than 6 months, major stone compound is calcium oxalate in 84%, and older children more than 6 months, major component is ammonium acid urate. Location of stone is kidney and bladder, and many of these children present past the stone spontaneously. So in conclusion, in endemic countries, infants with malnutrition, diarrheal diseases, and non-specific symptoms of fever, abdominal pain, restlessness, irritability, dysuria, and hematuria provide high index of suspicion for urolithiasis. Urinary chemistry helps identify risk factors, and together with stone analysis can lead to proper management and diagnosis of stone disease. I leave you with this picture of, it looks like a coral reef, but these are bladder stones from children with their various types. Some of these may remind of the problem we are having these days, the coronavirus. Thank you very much.
Thank you very much, sir, for giving this opportunity to know about the epidemiology and the causative factors of stone formation in Pakistan. As the data registry in Pakistan is already very poor, your work has definitely added to this. So now I move on to our next presentation by Brigadier Muhammad Amir Saab. He is working as an associate professor of pathology and head of chemical pathology, endocrinology, and toxicology at the Armed Forces Institute of Pathology. He's also been awarded with the Sitara Imtiaz Military, and he has a special interest in laboratory accreditation and quality assurance. He is also a program in charge of National External Quality Assurance Program of Pakistan. Brigadier Amir is also a College of Physician and Surgeon of Pakistan supervisor and examiner of chemical pathology. He has more than 30 publications to his credit, and I request Professor Amir Saab to please continue. Sir.
Assalamu alaikum, everybody. Before I start my presentation, I would like to thank the organizers for inviting me and giving me this opportunity to share what I have to say with the rest of the August Forum. The topic of my presentation is significance of toxicology screening tests in critical care settings. Before I start with the topic, I would like to quote Paracelsus, who is regarded as father of toxicology. And I quote, "All substances are poisons. There is none which is not a poison. The right dose differentiates a poison and a remedy." Unquote. Toxic injections and poisonings are one of the most important causes of ICU admissions all over the world. This ingestion or poisoning could be attributable to a deliberate overdose of the prescription drugs, accidental overdose, particularly in children, environmental and occupational exposure to the toxins, or attempted homicide or suicide. Patients are either critically ill or have a potential for rapid clinical deterioration. Therefore, early recognition of intoxication is a key to favorable outcome that depends primarily on two factors. Number one is the clinical recognition of the toxidrome. Toxidrome is a constellation of the clinical findings. And number two is running appropriate toxicology screening tests. Now, coming on to the clinical picture, we have a variety of clinical presentations that are known as toxidromes. These toxidromes could be categorized as anticholinergic, cholinergic, opioids, sedative, hypnotic, or sympathomimetic. These toxidromes have different features and they can be picked up and their nature can be identified by observing the symptoms in a particular patient. However, there are some certain limitations of the clinical examination. As few poisons, they produce specific physical signs. The history is unreliable in most of the cases, and many a times we encounter mixed drug overdoses, making the picture overlapping and difficult to point out a particular drug group. Therefore, lab report becomes absolutely essential in such cases. So, lab approach must have a purpose for the initial screening and then subsequent diagnosis of these poison cases. The analyst or the pathologist must know that it is neither possible nor necessary to test a large number of clinical toxins. But luckily, only up to 24 drugs or agents world over account for about 80% of the cases of intoxications. And the scope of toxicology tests that a particular lab is conducting will depend on the pattern of local drug usage and the available resources to detect them. Qualitative screening, which is capable of identifying a large number of toxins, is preferable than quantifying a small number of toxins because it's very important to identify the group of drugs which is causing the symptoms. Quantitative estimation, however, is done when the definitive treatment or the antidote is present for the toxin that is under investigation. Then no single analytical technique is adequate for broad spectrum drug detection. Therefore, a combination of several analytical approaches is required. And for that thing to happen, we also need a rapid speed of analysis with lesser turnaround time. And it is also important that this facility that the lab endeavors to start should be available on a 24/7 basis because there is no time for any emergency to arrive. Screening is also necessary to differentiate suspected brain death caused by CNS depressant drugs from true brain death because that is a key question many times in the clinical practice. And screening is also required in medical legal cases like suspected homicide or suicide. The drugs that are most frequently taken in overdose in our practice, they include paracetamol, salicylates, volatiles, for example, ethanol, methanol, ethylene glycol, opiates, benzodiazepines, antidepressants, carbon monoxides, and pesticides like organophosphate insecticides. Above all, we must remember that the notion that ordering a toxicology screen on every patient with suspected overdose will yield a definitive answer is incorrect. And we'll see in the coming slides why is it so. Then above all, there are certain drugs and toxins a person might present with, but they are not routinely screened for. These drugs include most of the antihypertensives, cardiac medications, hallucinogens, monoamine oxidase inhibitors, plants and their products, mushrooms, fentanyl, cyanide, metals, and household products. The specimens that are submitted to the toxicology lab for screening include urine, blood, which may be whole blood, plasma or serum, and gastric fluid. Urine is the most commonly used specimen for toxicology screening as it offers a large window period for detection of various drugs and poisons. Also, drugs and toxins, they get concentrated in the urine and can be detected for longer duration. However, the urine specimen and its findings have got a poor clinical correlation and therefore are used only for qualitative analysis. Urine specimen, about 30 to 50 ml, is usually required. It is collected in a sterile container without any preservative. If urine is not available, then blood can also be used as an alternative. It offers a small window period for detection, but has good clinical correlation. And it is particularly used when quantification of a drug or toxin is required. And we know that quantification is required in those cases where the specific treatment or antidote is available for management of the case. Blood is maybe collected in the EDTA or a plain container, and 3 to 5 ml is usually required for screening purposes. Coming on to the gastric fluid, the spectrum of detection is limited to ingested toxins only. It offers a very small window period for detection, and there is no clinical correlation, and the detection is also qualitative. It's no point in detecting, in quantifying the detected poison. It may be obtained if the patient vomits or through nasogastric aspiration, and it should be detected in a plain container. When we talk of screening tests, then cutoff values are very important. As you can see in this table, there are various drugs and their specimen cutoffs are appended in front of each drug. These are some other drugs like cannabinoids, barbiturates, amphetamine group, cocaine, phencyclidine, methadone. Now, coming on to the screening test, there are a variety of screening technologies available. Starting from the simplest one are the spot tests. These spot tests are rapid, qualitative, and are easily performed, and also they are not based on any instrument. Example being ferric chloride and Trinder's test on urine for salicylates. Once a test appears to be positive on screening on a spot test, then it has to be confirmed by a quantitative technology on the serum. Another method of screening for toxicological parameters is the determination of anion gap. The reference interval of anion gap is 8 to 16, and it can be an initial screening test in the poison cases, and it gives a clue to the offending agent, for example, salicylates, ethanol, methanol, and other toxins and poisons which tend to rise the anion gap. Osmolar gap, being another parameter, can be used for screening and is also can be done for volatiles, for example, ethanol or methanol, and it is measured by freezing point depression osmometry. However, volatiles are not detected by vapor pressure osmometry. Arterial blood gases can also give a clue to the clinical condition of the patient by indicating metabolic acidosis that may be present in ethanol or paracetamol or salicylate overdosage. Thin layer chromatography has been widely used in the past. It's a versatile procedure requiring no instrumentation. It has been an operationally relatively simple and inexpensive, and a large number of drugs may be detected, but it requires experience and skill. and it has largely been replaced by other chromatographic techniques. So now we are not doing TLC for screening different drugs and toxins. Immunoassays are the most widely used screening methodologies today. They're the most preferred and the most commonly used world over. They may detect a single drug or several drugs of a single class, for example, opiates. Detection limit or cross-reactivity of similar drug varies. It's easy to perform and widely available for use on automated instruments. And in fact, it is a method of choice for initial screening and may be used in the point of care testing. The immunoassays, I'll show some examples, like for example, fluorescence immunoassay used in urine. I've shown two instruments that we work with. In both the instruments, the principle is the same. The drug or the metabolites in urine prevents the binding of fluorescent conjugate to the solid phase on the detection zone, and the meter reads the fluorescence bound to the detection zone and reports the result as positive or negative. This is another instrument and evidence investigator, which is based on comparative immunoassay. This technology has discrete test regions or DTRs, which are bound on the biochip, and the biochip holds the antibody. This antibody combines to the analyte or the drug of interest in the patient specimen, which the presence of which is indicated by activation of the enzyme labeled antibody or the conjugate. Immunoassays have a certain advantages as well as disadvantages. The best thing about immunoassays that it can rapidly detect a poison or a toxin, and large scale screening could be done through automation. The disadvantage being that false positive results are common in this technique due to cross reactivity, so results may be confirmed, but they have to be confirmed by definitive methods. So given these limitations, one should be very careful and know the limitations while interpreting a positive result on immunoassay screening. We have to know that immunoassay usually detect drug classes. Different classes of drugs that are structurally related may test positive. For example, phentermine and pseudoephedrine testing positive in amphetamine screening, thereby implying that immunoassays are not specific, and there is always a risk of false positive results. That is why the drugs are calibrated in immunoassays at certain cutoff values to decrease these false positive results. And moreover, the results that are generated are presumptive, and therefore they need confirmation by GCMS and LCMS. So a laboratory that is engaged in immunoassay detection only must know the limitations and must know what lies ahead. The drugs that cause false positive results in the screening test include amitriptyline, bupropion, dextromethorphan, diltiazem, diphenhydramine, ibuprofen, naproxen, and fluoxetine. Similarly, one should be very cautious while interpreting a negative immunoassay result. The assays may not pick all the drugs in a class, for example, fentanyl, nalbuphine, and pentazocine. Therefore, when a pathologist is asking for an immunoassay kit, he must see the repertoire of that kit, that whether that that immunoassay kit can encompass all the drugs in a particular setting. Recent use of drugs like cocaine or heroin may not test positive, as the assay detects metabolites better than the parent drug. Some drugs are benzodiazepine-like, but not structurally related to benzodiazepine. So here are certain important reasons that must be considered before a negative result is interpreted. So these are the screening methodologies. Volatiles like ethanol or pesticides can be measured by simple colorimetric methods. Oximetry can enable us to measure carbon monoxide. Then estimated detection period for selected drugs and blood in the urine. This table shows different drugs and metabolites and their estimated detection periods in both blood and the urine. So this detection period might be handy before we interpret the result as positive or negative. This is the acetaminophen overdose nomogram, the Rumack-Matthew nomogram. It interprets the serum acetaminophen concentration in relation to time since ingestion in order to assess the potential hepatotoxicity. Now, our data for the last 5 years shows that here's the list of different drugs that are most frequently taken in overdose and for which a person might require admission in the intensive care. And we did more than 65,000, approximately 66,000 tests in these 5 years, and out of which approximately 2,000 reported positive, making a total percentage of 3% being positivity rate. So the carry home message of my presentation is that broad spectrum screening tests are used for initial screening in the intoxicated patients. These tests provide information despite limitations, and the information is very important. However, their interpretation requires application of skills and knowledge. I thank you all for your time.
Thank you very much, sir. Thanks a lot. Now, with the permission of the chair, so we'll carry on with the scientific session, and we'll start the first presentation of the scientific session. For this, I will call Assistant Professor Dr. Nabila Rauf to come onto the dais and invite the participants. Thank you.
Assalamu alaikum. I'm going to conduct a scientific session. Scientific sessions are one of the primary venues for scientists to present their new work at to their colleagues with the purpose of receiving feedback at an early stage of their research. For this session, I would like to request Professor of Histopathology, Professor Dr. Muhammad Sulaiman Khan, to chair this session, and also request to Professor Dr. Muhammad Shahbaz Hussain, Head of Microbiology Department, to co-chair this session. So please have your seats. We have 3 presenters from 3 different institutions. Each presenter has given 15 minutes, and at the end, we may have a question and answer session. Our first presenter is Dr. Aisha Habib, 4th year trainee of FCPS Chemical Pathology at Zayed University and Zayed Medical University, Karachi. She will present her topic of research, which is diagnostic accuracy of precalcitonin in neonatal sepsis. But due to some network issues, she cannot join us live. So we will share her presentation, recorded presentation.
Starting with the name of Allah, the most beneficent and merciful. Assalamu alaikum to all the respected supervisors and my dear fellows. I am Dr. Aisha Habib, resident of chemical pathology in the Dr. Zayed University Hospital, Karachi. And today I am going to present the diagnostic accuracy of procalcitonin in the neonatal sepsis. So, the rationale of my study is to see the diagnostic effectiveness of procalcitonin as a biomarker for early diagnosis of neonatal sepsis. I will start with the sepsis of introduction and will quickly move to the procalcitonin. As we all know that sepsis is defined as a life-threatening organ dysfunction caused by a dysregulated host response to the systemic infection. And the facts regarding sepsis is that the incidence of sepsis is greatly increasing despite the global initiative with a mortality ranging from 30 to 50%. And with each hour of delay in administration of antibiotic results in the increase of 7.6% mortality for the septic shock. There are the different stages of the sepsis based on the clinical signs. I will not go into the detail of this slide, and the mortality rate is highlighted in red. The diagnostic criteria of sepsis includes a temperature of more than 38.83 degrees centigrade or more than or less than 36 degrees centigrade, or heart rate of more than 30 beats per minute, respiratory rate of more than 20 beats per minute, or PCO2 of less than 32 mmHg, WBC count of more than 12,000 or less than 4,000, or immature neutrophil that is more than 10%. This criteria is taken from the Greenwood. Now, the current diagnostic tools which are available for the diagnosis of sepsis include the blood culture, the WBC count, lactic acid, C-reactive proteins, cytokines, and procalcitonin. Now, what is the history of procalcitonin? It was originally investigated as marker of medullary carcinoma of thyroid in 1970s. Relationship to sepsis was found in 1990s, designed to distinguish sepsis from the SARS. Procalcitonin is a 116 amino acid peptide which stems from calcitonin. Calcitonin encodes calcitonin. It's a pro-peptide hormone which lowers the concentration of calcium in the blood. The normal levels of procalcitonin is less than 0.46 nanogram per ml. Now, in normal condition, procalcitonin is secreted by the thyroid gland, lungs, and pancreas. But in case of a bacterial infection, it is produced and released in secretion from the entire body. Now, the indications of sepsis of procalcitonin. It is used for the confirmation or exclusion of diagnosis of sepsis, severe sepsis, or septic shock. It is also used for the severity assessment and follow-up of systemic inflammation. And it is also used in the individual patient adapted guideline of antibiotic therapy and focused treatment. This graph shows the kinetics of procalcitonin. As you see here, that the procalcitonin level rises 3 to 6 hours after the bacterial infection, and it got a peak in 12 to 24 hours. Whereas if in case of adequate infection control and effective treatment, its level going to fall down with a decline of less than 80%. Whereas when the infection is inadequate infection control, there is decline less than 80% from the peak history, and there is more than 20% mortality rates. So the method of estimation of procalcitonin is basically sandwich ELISA principle, that there is difference of method of detection, mechanism of detection of these complexes. These are the confounders of procalcitonin. That is, this level may be elevated in absence of sepsis when there is a presence of surgery, trauma, or burns. And if the newborns are less than 72 hours, there is naturally rise of the procalcitonin level. And in case of medullary carcinoma or small cell lung carcinoma or bronchial carcinoma, the levels of procalcitonin are elevated, whereas its levels are lower in subacute bacterial endocarditis or localized infections. Now, this is a very good picture. It shows the procalcitonin level and the use of antibiotics. As you see here, if this are the levels of the procalcitonin. If these levels are more than 10 nanogram per ml, we label it as septic shock. And if its level is more than 2 nanogram per ml, we label it as severe sepsis. Whereas it is for more than 0.5, we consider it as simple sepsis. And there's a between this is divided into 4 groups. That is, if the procalcitonin level is less than 0.1 nanogram per ml, antibiotics is strongly discouraged. And if its level is 0.1 to 0.25 nanogram per ml, antibiotic is again discouraged. Whereas the levels more than 0.25 up to 0.5 nanogram, again it is very much encouraged. And if levels of procalcitonin are more than 0.5 nanogram per ml, antibiotics are strongly encouraged. This is the procalcitonin algorithm for antibiotic therapy. Moving towards my study project, my objective was to ascertain the diagnostic accuracy of procalcitonin in neonatal sepsis using blood culture as gold standard. The setting of my studies to Zayed University Hospital, Karachi, and it was duration from March 2019 to December 2019. It's a cross-sectional study with a sample size of 171 individuals. The newborns from 2 days to 1 month of age are included in my study, which are admitted with the clinical symptoms of sepsis, and the females and female, both the newborns are included in my studies. And those newborns or neonates which were previously on antibiotics before the samples for blood cultures and procalcitonin were collected, they are excluded from my study, and those who have congenital disorders are also excluded. Now, this was my plan of study. After taking the informed consent and the written consent, I've taken the procalcitonin sample, the yellow top, and blood culture impacted were and they're analyzed. Basically, was in a Roche immunoassay analyzer. Now, coming to our stats, the quantitative variables are analyzed by mean and standard deviation, whereas qualitative variables are analyzed through frequency and percentages. Effect modifiers are studied by 2x2 tables. Moving towards the results, this graph, this table shows the descriptive statistics of neonates presented as clinical sepsis. As you see here, it shows the mean age, mean birth weight, mean gestational age, and the mean procalcitonin values. This is standard deviation and quartiles. Now the age and gender distribution. As you see, the newborns of 2 to 7, I've divided the newborns into 2 age groups, 2 to 7 and 8 to 29 days. And the numbers as shown here is also the male and female, 3% is shown also here. Now, this is the main diagnostic accuracy of procalcitonin in neonatal sepsis. This is the 2x2 table. I have taken the cutoff of PCT of more than 0.5 nanogram per ml as positive. So the true positive in my case is 84. That is those who have the blood culture positive as well as the PCT value positive. Whereas those who have blood culture negative value positive are 25, that is they are false positive. And two newborns are false negative, that is they have the blood culture positive but the PCT level is less than 0.5 nanogram per ml. Whereas 16 newborns are true negative, that is they have both the culture and procalcitonin negative. So the sensitivity of procalcitonin was found is 97.67%, specificity of 70.959%, positive predictive value 77.06%, negative predictive value 96.77%, with the likelihood ratio of positive test is 3.32, and LR of negative test is 0.033, with a diagnostic accuracy. Overall diagnostic accuracy in our study was found to be 84.21%. Now this is a comparison of other studies of my study with other studies, and all these studies have cutoff of more than 0.5 nanogram per ml. This is the ROC, that is the receiver operating curve, and it shows this is the value line showing the procalcitonin area under curve. Area under curve was 0.869, that is at a cutoff value of 0.5 nanogram per ml. And this is a comparison of area under curve procalcitonin and the CRP. I have also collected CRP levels of the newborns which are included in my studies. And this is a procalcitonin value and positive blood culture, mean procalcitonin value, and the standard deviation. Most common organism found in our study is probably negative Staphylococcus aureus. Most common 22%. There are various other organisms. I've also collected final reports of the culture. Okay, and this is a comparison of organism with the PCT value. Now coming toward the conclusion, it was concluded from my study that the PCT is a very useful diagnostic tool for early diagnosis of sepsis in newborn, showing 84.21% diagnostic accuracy as a cutoff value of 0.5 nanogram per ml. These are my resources. I am very much thankful for all of you, and it's a great honor for me to be a part of ChemCon 2020. Allah Hafiz, take care.
Thank you very much, Dr. Aisha Habib, for sharing us this informative presentation regarding your research on procalcitonin. Now, a second presenter is Dr. Ikra Sajid, which is second year trainee of FPS Chemical Pathology at Qaid-e-Azam Medical College, Bahawalpur. She is going to present her research topic, diagnostic accuracy of cystatin C over creatinine in detection of early chronic kidney disease on the basis of estimated GFR in type 2 diabetes mellitus in Qaid-e-Azam Medical College, Bahawalpur.
Assalamualaikum, it's me Dr. Ikra Sajid, PGR Chemical Pathology from Qaid-e-Azam Medical College, Bahawalpur. Today the topic of my presentation is cystatin C is a better biomarker than creatinine in detection of early chronic kidney disease in patients with type 2 diabetes mellitus. Bismillahirrahmanirrahim. The key points of my presentation will be risk factors of chronic kidney disease, diabetes mellitus, how diabetes affect the kidney functioning, chronic kidney disease and its stages, how will we estimate reduced kidney function, what is GFR and eGFR, then cystatin C, and then my own research. There are multiple risk factors of chronic kidney disease. The topmost among them are diabetes mellitus and hypertension. Other causes include family history of kidney disease, cardiovascular disease, recurrent urinary tract infection, or any autoimmune disease. What is diabetes mellitus? Diabetes mellitus is a disease, or it is a metabolic disease, metabolic disorder characterized by decreased insulin secretion or decreased insulin action or increased insulin resistance. And so two types, type 1 and type 2. The main defect is high blood glucose level. The high blood sugar level will affect many organ systems of the body, which mainly includes our kidneys, our eyes, cardiovascular system, etc. The prevalence of diabetic nephropathy or chronic kidney disease in patients with diabetes mellitus is 30 to 40%. Next, the point is how diabetes affects kidneys. Diabetes mainly affects on the basement membrane. It causes mesangial sclerosis or mesangial hardening, nodular glomerulosclerosis. It also affects our renal arteries, causing arteriosclerosis, and then pyelonephritis. These are the most common effects which occur in kidney due to diabetes mellitus. What is chronic kidney disease? Chronic kidney disease is abnormalities in either kidney function or kidney damage for more than 3 months. The duration will be of more than 3 months. The reduced kidney function will be when GFR is less than 60 ml per minute for more than 3 months, with or without kidney damage. It may present with kidney damage or it may present itself with reduced GFR. How can we estimate kidney damage? Kidney damage is manifested by either pathological abnormalities or through markers of kidney damage like proteinuria, albuminuria, or urine albumin to creatinine ratio. We all know there are 5 stages of chronic kidney disease. Normally, we have GFR of more than 90 ml per minute and kidneys are healthy. There is no damage to the kidneys. We will call stage 1 when GFR will be more than 90 ml per minute as normal, but there will be kidney damage. And stage 2, GFR will be 60 to 89 ml per minute. Stage 3, 30 to 59 ml per minute. Stage 4, 16 to 29 ml per minute. Stage 5, less than 15 ml per minute. Stage 5 is also called end-stage renal disease. As we move from stage 1 to stage 5, the GFR will begin to decrease and there will be increasing kidney damage. Next, the point is how can we estimate reduced kidney function? As we all know, GFR measurement is a direct assessment of kidney function. There are different methods of estimating or measuring GFR, either through endogenous markers or through exogenous substances. The endogenous markers which are most commonly used include creatinine, and a new emerging marker is cystatin C. And the exogenous substances which are used include inulin, iohexol, labeled EDTA, labeled iothelmate. In this way, give patient any substances from outside and then measure the rate of their clearance from the plasma. But they are tiresome and time consuming. That's why we prefer endogenous substances. Creatinine, as we all know, it is a breakdown product of muscle metabolism. It is excreted via kidneys. It is routinely measured through Jaffe kinetic enzymatic method. Then we can also measure eGFR to creatinine-based formulas like MDRD. Cystatin C is a new marker. It is a breakdown. It is produced by all nucleated cells and it is metabolized in the kidneys. It is routinely measured through immunoassays. And then we can also measure GFR through cystatin C based formulas. What is GFR? GFR is the glomerular filtration rate, or the rate at which glomerulus is filtering the blood. So as the functioning nephron begin to decrease, the GFR will decrease accordingly. It is a direct estimation of number of functioning nephron. What is estimated GFR? Estimated GFR is not the measured GFR, but it estimates the measured GFR. It gives a clue about the reducing GFR or normal GFR. It is through different equations, either creatinine or cystatin C based equations. Next, what is cystatin C? Cystatin C is a low molecular weight protein. It belongs to cysteine proteinase inhibitors family. It is produced by all nucleated cells in the body. It is filtered at the level of glomerulus and then metabolized in proximal convoluted tubules. Therefore, as kidney function is deteriorating, its level begin to increase. It is endogenous marker. It is not affected by age, sex and muscle mass. That's why it is superior to creatinine. Help in early detection of chronic kidney disease in patients with diabetes mellitus or hypertension. Early diagnosis and treatment of diabetic nephropathy improves the overall lifestyle of the patient. Now the point is, why cystatin C is more effective marker? In recent studies have shown that detection of chronic kidney disease in early stages, that is stage 1 and stage 2, when GFR is more than 60 ml per minute. Cystatin C is more effective at this point as compared to creatinine because it rise late, and also it is affected by muscle mass, age and ethnic population, while cystatin C is not affected by any of them. Now, introduction to my research. The methodology of my study was cross-sectional study. I conducted my study in Department of Chemical Pathology, Quaid-e-Azam Medical College in collaboration with Kidney Center. Total duration of my study was 6 months. I included all patients with type 2 diabetes mellitus with GFR between 60 to 90 ml per minute. Age of those patients were 40 to 60. Duration of diabetes was between 10 to 20 years. Fasting blood sugar was more than 126 and HbA1c was more than 6.5%. I included both genders. I excluded all those patients with CKD stage 3 and stage 4, hypertensive, patient with gross proteinuria, patient with history of steroid intake, hypothyroidism, chronic liver disease, or HIV, because all of these factors affect the cystatin C. A total of 60% patients were included in my study. 66% were males. Mean age of patient was 46.4 plus minus 6.48. Mean HbA1c was 8.5 plus minus 2.1. Mean creatinine-based eGFR was 94.4 plus minus 9.68. Mean cystatin C-based eGFR was 77.85 plus minus 12.86. Then interpretation of my study was using a GFR of 90 ml per minute as a cutoff. It was found that cystatin C has a sensitivity of 84% and specificity of 80% as compared to creatinine, which has sensitivity of 36% and specificity of 70% at GFR between 60 to 90 ml per minute. And I used sport urine albumin to creatinine ratio as a standard or reference method. Thank you so very much.
Thank you so much, Dr. Sajid, for sharing your wonderful presentation. Now, our next presenter is Dr. Amarul Hassan from Rawalpindi. He has done MPhil in chemical pathology from Islamic International Medical College and acquired knowledge and skills to pursue his career as chemical pathologist. Today, he is going to present his study, serum activin A and inhibin, possible biochemical markers of preeclampsia and pregnancy-induced hypertension. It's over to you, Dr. Amar. Please join us for your presentation.
Bismillahirrahmanirrahim. Assalamu alaikum. Thank you, Dr. Nabila, for giving me this opportunity to present my article, to my paper in front of all the senior members, respective. Today, I'm going to present my study serum activin A and inhibin A, possible biochemical markers of preeclampsia and pregnancy-induced hypertension. To start with, first of all, the brief introduction of the serum activin A and the inhibin. The activin and inhibin, they are the homodimeric protein, and there are three subunits of the activin: activin A, activin AB, and activin B. And they are linked by the disulfide bridges. And the inhibin, they are two subunits, inhibin A and inhibin B, and they are also linked by the disulfide bridges. The activin is present in the circulation in two forms. The one is the active and another one is the inactive one. The active form of the activin is basically the active. This follistatin is the glycoprotein activin and results into the competitive inhibition and resulting into the blockade of the signal transmission. The activin and inhibin, they are produced in non-pregnant women from the ovarian granulosa and the luteal cells, while in the pregnancy, they are secreted by the syncytial layer of the placenta. There are three types of the hypertension observed in pregnancy. One is the pregnancy-induced hypertension, preeclampsia, and the chronic hypertension. The pregnancy-induced hypertension is characterized as it begins after the 20th week of gestation with the blood pressure of greater than or equal to 140 by 90 millimeter of mercury on two separate occasions, 6 hours apart. The main differentiating point between the pregnancy-induced hypertension and preeclampsia is that in PAI, there is no proteinuria, while in the preeclampsia, there is a significant proteinuria of 0.3 gram protein per 24 hours. The basic pathophysiology of the PIH and the preeclampsia, that it results from the incomplete placentation of the spiral arterioles, which results into the defective trophoblastic invasion, and there is a decrease in uterine placental blood flow, resulting into the placental ischemia. This placental ischemia is basically responsible for the release of different cytokine factors along with serum activin A and inhibin A. The study conducted by Williamson R.D. et al. And Echolekar R. et al., they basically determined that the activin A and inhibin A are elevated prior to the onset of the preeclampsia, so they can be used for the risk stratification in the patient developing preeclampsia. Another study by Farzana F. and al., they determined that the inhibin A can be used as the predictor for preeclampsia, and it can be used as the screening test. The study by Shushala S. et al., they basically describe the mechanism that how this placental ischemia is responsible for the increase of activin A and inhibin A in preeclampsia patients. The international study mostly focused on the preeclampsia, which is more severe form of the disease. And if we diagnose the patient of the PIH at the early stage, so we can prevent the complications of the PIH, and mostly the patients of the PIH are asymptomatic and they are difficult to diagnose at the early stages. So with the help of serum activin A and inhibin A, we can diagnose the patient at an early stage and prevent the complication. No local study have been found after an extensive literature review on the significance of serum activin A and inhibin A as a biochemical markers of PAH and preeclampsia. The basic aim was to diagnose the patient of PAH and preeclampsia with the help of serum activin A and inhibin A estimation. Objective was to compare the levels of serum activin A and inhibin A in PAH, preeclampsia, and normal pregnancy. It was an analytical cross-sectional study conducted in Chemical Pathology Laboratory of Pakistan Railway Hospital under collaboration with Department of Gynae of Pakistan Railway Hospital and Fauji Foundation Hospital. The total duration was 1 year. After the approval from the Ethical Review Committee of the Rifa International University, non-probability convenient sampling technique was used. The inclusion criteria, we included the patients of PAH, preeclampsia between 20 to 25 weeks of the gestation, and in the third group, the control group of the matched gestational age was taken. We excluded patients of UTI, chronic hypertension, carcinomas, chronic disease, diabetes mellitus, and acute inflammation because they somehow alter the levels of serum activin A and inhibin A in circulation. The permission was taken from the Ethical Review Committee of Rifa International University, from the hospital administration, HOD Gynae Ops. Informed consent was taken from all the participants, and the anonymity of the participants were maintained by assigning them a unique ID number. The data collection procedure starts after the permission from the Ethical Review Committee, and then from the then we pick the cases from the Gynae Ops ward and antenatal clinic, the already diagnosed patients of the preeclampsia and the PAH. Then we take the detailed antenatal and past medical and personal history, and finally the inclusion and exclusion criteria were applied for the final selection of the patients. There were three groups: the PAH, preeclampsia, and the control group. The sample was collected in the Pakistan Railway Hospital, the 5 ml of blood from the median cubital vein, the serum extracted, centrifuged, and stored at -80, and then we analyzed all the samples in a single batch. The basic principle was sandwich ELISA, in which the micro ELISA plate was pre-coated with the antibody specific to human activin A and inhibin A. Samples added to the ELISA well and combined to specific antibody, and the optical, the wavelength was measured at the 450 nanometer. Data was analyzed on SPSS version 23. One-way ANOVA was applied to determine the statistical significance of serum activin A and inhibin A between the means of the group. Post-hoc Taki analysis to basically determine the exact difference among the three groups, and the p-value of less than 0.05 was considered as statistical significant. So the mean of the serum activin A and inhibin A was calculated among the different groups, and it was observed that it was highest in the preeclampsia, followed by the PAH group, and lowest in the control group. As you can see in this table, the mean of serum activin A in PAH group is 251, in preeclampsia it is 466, and in control group it is 43. The mean of serum inhibin A in PAH group is 194, in preeclampsia 349, and in control group it is 17.27. This is the graphical representation of serum activin A and inhibin A mean in different groups. Then we compare the serum activin A among the respective groups. The comparison revealed that first in the comparison was done between the PAH and preeclampsia, in which there was a significant mean difference of 215 with a statistical value with the p-value of less than 0.001, which is considered as statistical significant. Then the comparison between PAH and control group was 208. Preeclampsia and control group, it was 423. Similarly, the comparison of serum inhibin A between the PAH and preeclampsia group revealed the mean difference of 154 with a p-value of less than 0.001. PAH and control group, it was 177 with a p-value of less than 0.001. And preeclampsia and control, it was 331 with the p-value of less than 0.001. The study conducted by Lagana S. et al. And Fungi L. et al., they basically stated that the levels of the serum activin A and inhibin A, they vary according to the gestational age. So we take the patient, we have taken the patient in all the respective group into the narrow gestational age to minimize any variation in the levels of the serum activin A and inhibin A. The study conducted by the Williamson RD et al., they basically stated that the increased levels of the serum activin A and inhibin A, they are also associated with the other anomalies and the miscarriages. The study by the Akulaker R et al., they have taken the sample from the uterine artery and they compared the level among the preeclampsia and the control group. Shushala S. et al. And the Hobson S. et al., they concluded that the serum activin A and inhibin A levels are increased in the PIH and preeclampsia group. So we have concluded that the significantly serum activin A and inhibin A levels are significantly raised in the PIH and highest in the preeclampsia patient. Measurement at 20 to 25 weeks of gestation can be useful for early detection of the PIH and preeclampsia. The estimation can be helpful to prevent the complications of the PIH and preeclampsia like the eclampsia and the HELLP syndrome, which are the more severe form of the disease. The assay is cost effective and can be conducted at any setup having a facilities of ELISA. The basic limitation of the study was it was a cross-sectional analytical study in which the cause to effect relationship of the disease cannot be established. The sample size was small due to the financial constraints, study duration, and limited resources of the subjects. The longitudinal study should be carried out to basically assess the pattern of rise and fall of serum activin A and inhibin A in normal pregnancy, PAH, and the preeclampsia, and the other complications of the hypertensive disorder of the pregnancy. A large-scale prospective multi-centered clinical trials are required to establish the importance of serum activin A and inhibin A in PAH, preeclampsia, and other complications. This was the performer, consent form, and these are the results.
For your innovative and informative research you have shared with us. Now I would like to call chairman of this scientific session, Professor Dr. Mohammad Suleiman Khan, to say his concluding remarks regarding these presentations. Sir, please.
Bismillahirrahmanirrahim. I take the opportunity to conclude the session. Earlier on in preliminary session, the speakers were very eminent and they have got a profound impact on our faculty and the PGR also. But at the same time, I must not forget to say, participants are all parts and parcel of the learning process. So about three speakers, namely the Professor Dr. Aisha Habib from AQU, and then is the Professor Dr. Naki Mirza. Yes, I must conclude the earlier on also. And lecture by the Brigadier Amir Sahab has been throughout on the very important and common topics and has been made very easy, concluded earlier on by the Dr. Sabath. So I really appreciate these on my behalf as a chairman of the session of the today. Now we come to the various presentations by the PGR of their research topics. Dr. Aisha Habib from Ziauddin Hospital University on the procalcitonin has been a very good topic in the neonatal sepsis. This is a very clinical topic, and the basic departments are taking interest in the clinic because the pathology is altogether the applied. don't think we just perform the test, we are rightly involved into the diagnostics and certainly saving the lives like other clinicians. So this is a very good topic, and I must say the research methodology has been followed rightly in all the three presenters in the scientific session. Second presentation is by the Dr. Ikra Sajid from QMC, and then is the Amarul Haq. All these were very up to the mark, and I really appreciate these youngsters to taking part in the research activity, because all of our posts are meant for the academic and research activities. And these eminent professors who are backing up there as a supervisors, certainly it's reflected, they are indexed in that presentations. And no doubt, our team at SZMC is very much powered by such knowledge and skill. Namely, the leader of the dynamic of our team, Professor Dr. Abdurrahman Sahab, HOD of the pathology, and so many other very good professors like Dr. Shahbaz, and Associate Professor Balal Ghafoor, and Dr. Sabat Heather, Associate Professor in the Chemical Pathology. So all this event has been very timely and very attractive because of the Dr. Sabat. I must not forget, if I don't name her, so I will be not a good person at all. So we have been throughout there writing all the presentations. I am just saying what on the basis of evidence this is, because all the time I was just in front of the screen writing points like a student, because learning is a continuous process. You have to remain student throughout. If you think yourself like this, you may rise up to the any level. And inshallah, we pray for all of you. We must have benefited from the all speakers, and I am very thankful to the learned professors who have just delivered in the session for the last 2 days. And the scientific session has been very good, and I realize our PGR at SZMC would have taken an advantage how they can work with the research methodology in their topics also. So this has been ample source of learning, and we were just missing it for the next session, inshallah. May Professor Abdul Rahman stay here with us in his next 3 years. We hope for that. And ये गुलशन ऐसे ही चलता रहे. So इसलिए ये बड़ा ज़रूरी है कि we have got a very good team here, and expertise are always important, and experience is such a good thing. Nothing matches that. We all have the degrees which are right at our credit, but what is very important is how much we depict and how much we are beneficial to the patients. In this presentation, there has been a good combination by the gynae and chemical pathology, and by hematology and others, microbiology and others. So this is a diversity and the beauty of the presentations, because all were applied and they were the clinical based presentation, and pathology itself is a applied one. How much we are beneficial to the patient, this is important, and this will rate over hereafter, life here and the hereafter. तो इसलिए जो है सबसे अच्छा टेक होम मैसेज यही है कि जो इल्म है उसको हम ज़ाय ना होने दें. फकत यही वो चीज़ है जो खर्च करने से बचे. थैंक यू वेरी मच.
Thank you very much, Professor Salman Saab, and for his beautiful words and the nice depiction of the scientific session. Actually, sir, we had many presentations, and because of this constraint of this COVID-19 and the time-bound conference we have to carry it out, so we just selected the only 3 from 3 different institutions and cities. And these, it doesn't mean that the other presentation were not up to the mark, but actually those are also very good papers. But because we were constrained with the time and the location, so that's why we just selected these 3, and these 3 presentations, scientific papers, which collaborated with the microbiology, with the gynae and ops, and the third one, and the first one actually was about the procalcitonin, which is actually the lecture given over by Professor Asma Shaukat yesterday. And this newly discovered marker, procalcitonin, has been serving as a marker of infection for the patient of COVID-19. The risk stratification and the therapy strategies are based on this marker too. This marker is available from the Khan also. So thank you very much, sir. I once again thanks all the participants. There are 59 participants till now online with us. And now I will request the participant online that they give us a break of 15 minutes for the tea, because we have got our dignitaries here, our HF departments and the guest. And after 15 minutes break at 11 o'clock, we will start with the workshop. And the workshop will be conducted by the Professor Amireja's first part, and second part will be from consultant pathologist Dr. Lina Jaffrey from Khan University. So stay with us, give us a short break, and we will join again. Thank you very much.